Star always in reaching our conferences. Professor Dr. Wael Saad, and he's going to give a talk about fallopian tube recanalization restores hope.
Thank you, Mr. Chairman. Changing gear from intravascular to extravascular, talking about fallopian tube recanalization for infertility. Primary infertility is not able to conceive as a couple, as the same couple, for 24 hours, and secondary infertility, unable to conceive as a couple, as a single couple, for 12 months. Etiologies of infertility are extensive and way beyond this meeting, but they're either divided into male and female causes, and one of these female causes are tubular disorders. And so it represents about fallopian tube issues, probably represents about 25 to 35% of female infertility, and 20% of those are isolated proximal tube obstruction, which is the primary phenotypical indication for a fallopian tube recanalization. It has to be proximal, not in the mid or distal portion of the fallopian tube. The role of FTR is established and it is recognized by the American Society of Reproductive Medicine and the Royal College of Obstetricians and Gynecologists. Alternative to FTR would include fallopioscopic tubuloplasty and assisted reproductive technologies. It cannot remedy salpingitis, isthmic nodosum, and fibrio phimosis in any way. It's just a proximal tubular obstruction. When do you do it and how do you do it? You do it within the first 10 days of the cycle. In other words, counting from the first day of menses for 10 days. Must have a negative pregnancy test for sure. And you give them doxycycline as a prophylactic antibiotic, usually 1 to 2 days before the procedure for a total of 5 days. So it's like one day before and 4 days after. IV sedation is not necessary, but is optional, especially in the United States. The position is either a lithotomy or a modified lithotomy position, like a frog leg appearance. You get a warm speculum, especially if it's a metallic speculum. A cervical prep, usually with betadine. And some sort of an occlusive transcervical sheath. There are kind of two general subtypes of those. There's what in the United States we call a Christmas adapter, a Christmas tree adapter, which is kind of like a plug into the cervical os. And then the more common types nowadays are balloon occlusion catheters that you can go coaxially with catheters and wires through. There's a balloon here filled with air, and it shows you what you should see, just like you see on the right, is the tube is patent. It spills readily into the peritoneum. To your right is normal, to the left is actually abnormal and is obstructed, and it's a proximal tubular obstruction. Just to show you kind of the magged up, and that's the proximal tubular obstruction. That's abnormal, that's what you're going after, and to your right is actually what is normal. Starting off with the hysterosalpingogram, like we said, it's the same thing for hysterosalpingograms, 10 days from the beginning of the cycle. You usually use 30% diluted water-soluble contrast, and now recently some people will actually use lipiodol. Lipiodol is controversial. Some people believe in it. That actually has superior patency, and some people actually do not believe in it. There are about 6 randomized controlled trials comparing water-based contrast with lipiodol, and it's shown that it has a higher pregnancy rates, no differences in miscarriage or ectopic pregnancy. It does have issues with granulomatous formation and thyroid instability, either hyperthyroid or hypothyroid after the procedure. One of the prohibiting things about Lipiodol in the United States is that Lipiodol is very expensive in the United States. It's about $1,600 to $1,600 for one ampoule. In Egypt, your Lipiodol is subsidized, so it's very cheap. But in the United States and in Europe, it is very, very expensive. It ranges between $1,400 and $1,800. So that's one of the disadvantages of hysterosalpingogram with Lipiodol in the United States. So for reopening the fallopian, there are 3 stages with varying degrees of aggression or escalating degrees of aggression. First, you're starting off with a hysterosalpingogram with Lipiodol or with water-soluble contrast. Your next step is to actually try a 4-5 French angled catheter like a Compi catheter, directing it at the fallopian tube ostium and flushing it aggressively to try to flush it open. And your third step, which is the most aggressive you can do, is passing a hydrophilic wire through the lumen of the fallopian to try to open it up. Now I'm going to show you some examples. This is readily spilling on the left side there. So this is just hysterosalpingogram opening it up by pressurizing. So initially you don't see it on the right. By pressurizing the system and injecting contrast, it actually does spill over. So you're flushing it, and then you just open it, just using a hysterosalpingogram. Your next step, as you can see here, the fallopian tube on the left is occluded. They put a 5 French catheter right up at the ostium and then flush through, and it actually opens it up just by flushing that. And usually they're done by that, just by pressurizing hysterosalpingogram or a direct 5 French flush. Next step is another one here with direct flushing, and basically it opens it up. You didn't see it initially. It's spilled on the left, occluded on the right. So you put a 5 French catheter, you flush it through, and it basically opens up on the right and readily spills. And then you're done. Here's another example. You have occlusion. You put a wire up. This is actually, I don't know if you can see it, but this is actually a hydrophilic wire pushed up to the right fallopian tube and opens it up with ready spilling, and then directing it towards the left fallopian tube now that's also obstructed, passing a wire through that and opening that up. And here's another example where you can actually use coaxial systems, a microcatheter through a directional catheter. It's actually a coaxial crossing catheter for PAD that was actually used with a crossing catheter, a microcatheter crossing catheter through the fallopian tube, and then a hydrophilic wire through the crossing catheter, like a CXI catheter, for example, pushing it through the microcatheter and then through with a hydrophilic wire and opening up that right fallopian tube. And I'm now kind of showed you kind of the 3 degrees of aggression: hysterosalpingogram, direct flushing, and then coaxial with a hydrophilic wire through a 5 French catheter, and then a combination microcatheter, 5 French base catheter, and a glide wire. General outcomes: the technical success is about 60 to 90%. Tubal perforation is less than 2%, but it's clinically inconsequential. Infections are actually quite rare. The re-occlusion rate within a year is actually high, so you're looking at a 1-year period of patency, and then at a year, 40% or maybe even more than 40% re-occlude. About 25 to 30% successful pregnancy after fallopian tube recanalization. Like I said, with the randomized controlled trials, it's higher with Lipiodol than with water-soluble contrast. 6 to 7% miscarriages. That is no different from baseline and no difference in the ectopic pregnancy from the general population. In summary, it's for proximal occlusion, okay? It's done within 10 days of the first 10 days of the cycle, using doxycycline before and after for a total of 5 days. You can use a Christmas tree adapter or a balloon occlusion catheter. There are 3 degrees of aggression, hysterosalpingiography only, then direct 5 French flushing, and then a hydrophilic catheter or a combination coaxial microcatheter system with very good results. Technical success, like I said, is pretty high. Unfortunately, the reocclusion within a year is about 40%, but it's 25 to 30% pregnancies after successful fallopian tube recanalization. Thank you.
Thank you, Dr. Wael. It was such amazing presentation. Any questions?
Dr. Wael, which type of wire do you use? The 018, which type of
018
wire?
glide. 018 glide. Glide wire.
Glide wire, just a glide wire.
Just a Terumo. But it's been, originally it was described with a cope wire. So you can use a cope wire, you can use a, but mostly we prefer hydrophilic wires, like an 018 Terumo.
Thank you.
Any questions?
Dr. Wael, thank you very much. I want to ask you about also your experience in tubal coiling, because I know tubal coiling in cases of hydrosalpinx, for example. And
Yeah, we don't do those.
You don't?
Yeah, no, we don't. So I have no experience with that.
yeah. But we needed to see the photo with you beside the pregnant women, because he has been telling me that all the pregnant women, you had their photos. So
I didn't put it in the presentation. We good?
Any questions?
Thank you.
Thank you, Dr. Wael. Next speaker will be Dr. Rana Tarek.